Thank you, and I would like to thank Ruben and Mort for inviting me annually to the meeting. I always enjoy myself in New York, and their meeting always is very educational. So I have the pleasure of talking about other drugs that have been part of maintenance therapy, and I would certainly just start out by telling you that I use maintenance therapy. So the question is, what are the roles of the different drugs, and have they been clearly established? And I'll try to walk through that over the next 10 or 15 minutes. So first of all, the goals of maintenance therapy are to reduce the risk of relapse, extending progression-free, and hopefully the ultimate goal, overall survival. So we want to maintain the response that's been achieved following a new treatment with administration of drugs for a prolonged time period. But that therapy has to be convenient, hence an oral formulation is certainly preferred, or of infrequent parenteral administration. It needs to be safe and well tolerated, not in the short term, but the long term. And it should not prevent the use or reduce the efficacy of subsequent treatments. And I think that's most important, as these patients live not just for a few years, but many, many years, and they need to avail themselves the opportunity to get new drugs, hopefully not reduced by the maintenance treatment. So what are the questions? Well, in what setting? Front line or greater than or equal to second line? We've heard a lot about front line. We haven't talked much about using maintenance drugs in the salvage setting. And of course, that's where most of our data is front line. How long to maintain this maintenance treatment? Until the relapse or fixed length of time? Trials have been done both ways. And you have to know that there's really been no randomized data looking at fixed time versus till relapse in any trial. So which agents? How many to use in the setting of maintenance therapy? What about their doses, their schedules? There's very little data for randomized trials comparing different maintenance regimens as the only part of the randomization. As you'll see subsequently, these trials that have been done have had multiple randomizations, complicating their analysis. So the early trials involved alpha interferon, largely led by Heinz Ludwig from Vienna, and there was a suggestion, perhaps with a lot of toxicity, that you could extend survival, but one certainly is not using this much today. But I will tell you, in antibody conjugate work we're doing in our laboratory, it's a pretty exciting drug, it turns out, but it has to be targeted to the myeloma cell. About a decade ago, I published as part of a SWOG trial I did with Drs. Barloghi and the late Dr. Salmon leading the initial work in the trial, that simply using prednisone 50 milligrams every other day, believe it or not only prolonged progression-free or event-free, but also overall survival following patients who had a response to VAD. And the V in those days was vincristine, and much of the responsiveness of these patients was DEX. So it's as if these patients had an in vivo drug sensitivity to DEX and then continued it. And I think there's a lesson to be learned from that. In terms of thalidomide maintenance following transplant, we've heard a good summary of that just a moment ago by Sergio. I want to point out a couple of caveats. The first one is in the Atal IFM trial. This wasn't simply patients getting thalidomide alone. They actually got thalidomide with pamidronate, the bisphosphonate, versus pamidronate alone, and another arm had no maintenance therapy. And you'll also note in the Spencer trial, this was not thalidomide alone, it was actually with steroids versus steroids alone. And you'll note the different doses ranging between 200 and 400, which those three trials suggested some efficacy, whereas the European Lockers trial at the low 50 milligram dose actually suggested a disadvantage. So dose may be important, as well as the partner drugs such as the bisphosphonate. And in that regard, it's important to keep in mind that we and others have shown a plethora of anti-tumor effects of these bisphosphonates, whether it be pamidronate or zoledronic acid, direct pro-apoptotic effects, as well as a number of indirect effects, taking away cytokines that are either pro-apoptotic or anti-growth factors. Anti-angiogenic factors have been demonstrated to be blocked, as well as the progression of angiogenesis in the presence of bisphosphonates. And recent data suggests conversion of macrophages from an M2 to a pro-immunologic and anti-tumor M1 reversion in these tumor-associated macrophages in the presence of zoledronic acid. And data from a number of groups has shown a reduction in adhesion of myeloma cells to stroma in the presence of bisphosphonates, making them ripe for the picking and more sensitive to anti-myeloma treatments. And certainly we and others have shown marked synergism in the laboratory, both in vitro and in vivo with these agents, with older agents, let alone newer agents. And of course, there's a lot of work on the immunostimulatory effects of these agents, especially their effects on the V-gamma 9 delta 2 T cell subsets. It's led to immunologic-based trials using bisphosphonates. Now, what do we have in the clinic? Well, we have 2 trials that show some suggestion, one definitive, one not, in terms of overall survival. So this older French trial involving VAD and then high-dose therapy, double, followed by either pamidronate alone, pamidronate and thalidomide, or no maintenance therapy. And indeed, it's the doublet of the pamidronate and thalidomide that showed a strong suggestion, although not statistically significant, in favor of overall survival. Again, this was not a thalidomide alone arm. More definitive, as Dr. Morgan, who was here earlier talking about other things, was his MRC myeloma 9 trial, in which monthly IV zoledronic acid, given at 4 milligrams until progression, and then dealer's choice on whether patients wanted to continue. And in the other arm, patients received the weak oral bisphosphonate clodronate until progression, and then dealer's choice. And the trial in which these patients also received anti-myeloma therapy demonstrated in the bottom half not only a progression-free survival advantage, but an overall survival advantage as well, suggesting that these drugs have their effect not only on bones, but perhaps on the myeloma or the microenvironment or the immunologic system, but lo and behold, they do prolong survival. Now let's come to bortezomib as maintenance treatment. Not a lot of good randomized data that clearly defines its role today. This is the trial from Antonio Palumbo. It's VMPT with, unfortunately, maintenance VT in one arm and the other arm VMP. So we have newly diagnosed myeloma patients who were stem cell transplant ineligible, who were randomized to receive melphalan with Velcade and prednisone and thalidomide in the top half of the slide, and they went on to maintenance Velcade with thalidomide, and the other group, unfortunately, got VMP, and as you see in the bottom right, there was no maintenance therapy. So it's very difficult, of course, to tease out what is the exact effect of VT maintenance when you have 2 different inductions. And indeed, it's clear that with the VMPT, with the VT, you prolong the progression-free survival versus VMP from a median of 25 to 35 months, and the time to next therapy about doubles from 27 to 47 months. Both of these p-values are certainly significant. And in the next slide, when you look at overall survival, again, you do see a slight significant advantage, VMP versus VMPT. VT is superior with a p-value of 0.04. And all of the bottoms, the 5-year PFS, time to next therapy, overall survival, and overall survival from relapse, however, was not different. Now, there has been an attempt to do what was mentioned by Sergio in landmark analysis, looking at patients after they finish the 9 cycles of induction VMPT or VMP. And it does suggest that even after that time point, there's more than a 50% reduction in the risk of progression among patients who receive the 4-drug regimen with VT maintenance, suggesting or hinting at the role of VT being positive in this study. The Joven study is the other large study, but again problematic, as you see on the right-hand side, because we have one group getting bad therapy, that is bortezomib, adriamycin, doxorubicin, not pegylated, with dex, stem cells collected, and then having bortezomib maintenance every other week at 1.3, which is, by the way, what we do in our clinic. And on the bottom half, good old VAD with the vincristin, stem cells collected, and then thalidomide maintenance. So we have 2 different inductions and 2 different maintenances. And the trial does show, as you see in the upper left-hand side of the slide, a progression-free survival advantage in favor of PAD, the old name for Velcade or bortezomib, PS, as some of you know, for proscript. And on the right-hand side, a trend, but not significantly favored PAD over VAD in terms of that. But again, we do not have the same back end here in this trial. Now, the Spanish have also used bortezomib as a maintenance therapy for previously untreated patients. In this trial, as you see in the middle, they have inductions of thalidomide dex for 6 cycles with VTD, Velcade thalidomide dex, or older therapy, VBMCB/VBAD, which V has been Christine in there. And then those patients get bortezomib for 2 cycles, followed by a stem cell transplant with melphalan 200. And then they are further randomized to either bortezomib 1, 4, 8, and 11, but every 90 days with daily thalidomide, so-called VT, or thalidomide alone, or interferon for 3 years. And as you see, the response before maintenance is not very different between these, but on the bottom half, the improvement with maintenance slightly, but only slightly, increases CR rates among those with VT. However, when you look at the follow-up after 35 months, although PFS in the VT arm, bortezomib with thalidomide, outstrips thalidomide alone or interferon in terms of progression-free survival, there's absolutely no difference between any of the arms in overall survival, although the bortezomib-containing regimen, that is VT, did show a significant PFS advantage for patients with only low risk but not high risk cytogenetics. And of course, in the bottom, you do have to pay the piper a little bit in terms of toxicity. Now, there has also been another Spanish trial. This is a multi-center, 2-stage randomized study for older folks who were not transplant candidates. The initial induction was VMP in one arm, and in the other arm, it's VTP. The bortezomib, you can see, was twice weekly for 1 6-week cycle, and then 5 5-week cycles, bortezomib at a weekly dose. And then the second randomization, a 3-year treatment either of bortezomib with thalidomide, so-called VT, or bortezomib with our old friend prednisone that we did in the SWOG trial, 50 milligrams every other day, and there was randomizations done between each of the VMP, as you see, in the VTP arms. Now, if you look at the data, there's absolutely no difference in the PFS and the OSS between the VMP and the VTP arms, and no difference between the randomized groups to VT or VP, so it didn't really show any difference. So I would tell you that the role of maintenance therapy with novel agents has certainly not been clearly defined outside of what we've heard earlier from Dr. Giral with lenalidomide. I think there's a lot of limitations, as you saw in the trial designs. The long-term use of these agents, however, appears to be safe with bortezomib and steroids, but better trial designs are really required to clarify the role of maintenance treatment for our myeloma patients. What specific drugs to use, single agent versus combinations, doses, schedules need to be better defined. The length of therapy, should it be fixed as it was in some trials or to progression? What endpoint should we use, PFS or the more important overall survival? So what do we do in our clinical practice? Well, maintenance therapy is used for all patients responding not only in the front line but the salvage setting. Drugs are continued to progression of disease. However, drugs doses may have to be reduced or discontinued due to toxicity. But drugs that are continued, those are ones that have been part of the initial treatment regimen or the salvage regimen to which the patients responded, except chemotherapy. We don't continue the cyclophosphamide, the melphalans, the adriamycins. New agents are not introduced during maintenance. We like to say the devil you know is better and shown to be effective than the one you don't. So if you're adding new agents, you're doing new therapy. We use steroids at the equivalent dose intensity per month, 160 of dex per month, although we like oral methylprednisolone every other day, with or without IV dex every other week. Bortezomib we do use every other week at the 1.3 dose subcutaneously, And we do use the IMiD drugs, but we use them in patients who've responded to IMiD-based regimens. The lenalidomide at 10 for 14 days, if that's what we'd used in the prior regimen, or for 21 out of 28, if that's what's been included. Thalidomide is also used, 50 or 100, often needs to be tapered because of the onset of neuropathy. And we do continue zoledronic acid monthly. And I think that's it. Thank you very much.